That's right, we are back. This is the Ethnic Health Disparities Podcast show. My name is Dr. B, and we are back. This is show number 9. Show number 9! That's right, show number 9 of the Ethnic Health Disparities Podcast show. And we are moving right along, investigating, reviewing the Center for Disease Control and Prevention, CDC's report, Health Disparities and Inequalities report, United States 2011. And now we're going over health outcomes morbidity. That's right, health outcomes morbidity. That's right, it is our time, and this is number 5 of the report. So in the previous shows, we investigated. In the previous shows, show number 8, we looked at, oh my gosh, show number 8, wow. We looked at health outcomes mortality. Yes, we did. And show number 7, we looked at analyzing the health disparities, environmental health. So, but this is show number 9, and we're looking at examining health outcomes morbidity issues in this report. So welcome. Yes, this is Dr. B, and these shows are breaking down the issues. That's right, breaking down the issues. And I'm getting to the point, breaking it down for the entire U.S. And I feel committed that we review this data right now. And you can but review the other podcast shows. And I'm having fun doing these podcast shows, quite frankly. This is a new outlet for me from the university classes to these ethnic health disparity podcast shows. And I hope you're enjoying these, because I know you are, because I'm getting the emails, I'm getting the responses. And by the way, if you have any questions, please do not hesitate to email me at ejb678@gmail.com. And please do subscribe to the podcast shows. We are on, yes, iTunes. We are on Spotify. We are on Podbean. And yes, we are on YouTube. So we're out there even more so. And I'm sending these, let me just let you know. I'm sending these podcasts. These podcasts are going to all the federal agencies. Because I used to work for the federal government. Yes, I used to work for the federal government at the National Institute of Health, at National Cancer Institute, and the National Center on Minority Health and Health Disparities from 1999 to 2004. Yes. So, I still do have colleagues there. So, I know they appreciate this. Yes, they do. So I'm bringing that experience, not just my academic experience, but my practical federal government experience. So that's the reason why I feel compelled to review these documents from CDC. I'm 3 minutes in, 3 minutes and 50 seconds in. Let's get to our show. Again, all rights and responsibilities of these shows belongs to Dr. B and the Ethnic Health Disparities Podcast show. That's right, we having some big time fun, but we also breaking down these serious issues. And these serious issues in this particular podcast show number 9, we're looking at health outcomes, the morbidity, the conditions of being diseased. That's what morbidity is about. It's not mortality, what you die from, but morbidity, the disease state. And in this report, CDC report highlights 7 morbidity issues. I'm counting them. Yes, I'm counting them. 7 morbidity issues from their report. Now, let me just go through this report, the major issues real fast, right up front. The health outcomes and morbidity issues that they highlight are obesity, preterm births, potentially preventable hospitalization, current asthma prevalence, HIV infection, diabetes, and hypertension control. That's right. Let me read this again. Obesity, preterm births, potentially preventable hospitalization, current asthma prevalence, HIV infection, diabetes, and hypertension control. So let's go through some of the key points. I want to hit some of the key points. I'm starting off with obesity. The analysis states specifically, we're going through the CDC report. Hello, folks. And I'm breaking it down for everybody. We're not letting CDC just report these data and not have a response from the general public. Hello. So under obesity, United States, 1988 to 2008, the analysis found that racial and ethnic differences have not changed substantially during 1988 to 1994 and 2007 to 2008. Among the majority sex age groups, the prevalence of obesity is lower among whites than among blacks, among blacks. Hello, African Americans. And Mexican Americans. Among females, the prevalence of obesity is highest among blacks, African Americans, whereas the prevalence among males aged 20 years and less is higher among Mexican Americans. An inverse association exists between family income and obesity prevalence among white females, all ages, and white males, 2 to 19 years of age, but the association is weak or is positive among black men aged 20 years and greater, among other groups. Racial and ethnic differences in obesity prevalence persist after controlling for differences in family income. Hello. Randomized controlled trials have revealed that dietary modification and increased physical activity are effective. Wow, what a revelation. So in essence, of obesity, they're saying that it's lower among whites than among blacks and Mexican Americans. Yet the prevalence is highest among black female. Yet they really do not provide, and they just some generic interventions such as healthy eating, active living, increased emphasis on environmental strategies. That's not helpful, folks. That's not helpful when we have an increased obesity among specific racial and ethnic populations in the United States, particularly among black, female, and Mexican Americans. Hello. What are the suggestions for intervention? It's not provided in this document right up front. That's my biggest issue with this report. You report the data, but let's get specific on the intervention. It's time. Let's move on. Preterm births. This really is starting to get to me more than you can imagine. Approximately 1 in every 5 infants born to non-Hispanic black mothers in 2007 was born preterm, compared with 1 in every 8 to 9 infants born to non-Hispanic white and Hispanic women. So it's 1 in every 5 for non-Hispanic blacks, 1 in every 8 for non-Hispanic white and Hispanic women. The 2007 preterm birth rates for non-Hispanic black infants was 59% higher than the rate for non-Hispanic white infants and 49% higher than the rate for Hispanic infants. Understanding the causes. Now here's a key point in this report. Hello. Understanding of the causes for these wide disparities in preterm risk is limited. Oh my gosh. Reported causes include differences in socioeconomic status, prenatal care, maternal risk behaviors, infection, nutrition, stress, and genetics. Multidisciplinary research into the factors influencing preterm birth is needed for developing effective intervention strategies. In essence, they are clueless. Hello. They are clueless with regards to what is happening to the preterm births among non-Hispanic black mothers. They're clueless. Of course, they say causes, differences in socioeconomics, prenatal care, maternal risk, stress, and genetics. Wow. They're clueless. What is happening for preterm births among non-Hispanic black mothers? And this is not only 2000. This is happening in 2019. Hello. They're clueless. They wouldn't say that, obviously. But they are clueless. What are the factors? This is what teased me off. You know, come on, just say not that we are limited. That we are limited. Says understanding of the causes for these wide disparities in preterm risk is limited. Just say you're clueless. You're clueless, even in 2019. Wow. Okay, let me get through this. I'm 11 minutes in. Potentially preventable hospitalization. This is the next issue. During 2004, the rate of preventable hospitalization was higher among non-Hispanic blacks and Hispanics compared with non-Hispanic whites. In addition, the rate was lower among Asian and Pacific Islanders compared with non-Hispanic whites. During the same period, the rate of preventable hospitalization was higher among residents of two lower income neighborhood quartiles compared with the residents of the highest income neighborhood quartile. Communities can use information about preventable hospitalization to guide redesign of primary. Now, that's policy statement. But in essence, we realized the rate of preventable hospitalization was highest among blacks and Hispanics. That's before the effect of the Affordable Care Act. Hello. We'll get to that down the road. Number 4, current asthma prevalence. Now check this out. This is very powerful. During 2006, an estimated 7.8% of the U.S. population had current asthma. Asthma prevalence in the United States varied among demographic and economic groups. Current asthma prevalence was higher among multiracial Puerto Rican Hispanics and non-Hispanic blacks than among non-Hispanic whites. Current asthma prevalence also was higher among children than adults, among females than males, and among the poor and the near poor and non-poor. So they mention multiracial. That's very interesting. Of asthma rates. Puerto Rican Hispanics and non-Hispanic. What is happening? Why is this occurring? And in this report, in this segment of the report, they don't provide any plausible explanation for this data. Why is it happening among multiracial individuals? Puerto Rican Hispanics and non-Hispanic blacks. Hello, come on, give us some connecting factors. There is something happening here, folks. Okay, next major health outcome: morbidity, HIV infection. Very important. The data analysis indicates a total of 35,526 persons aged 13 years and older received a diagnosis of HIV infection in 2005 in the 37 states, including analysis, compared with a total of 34,038 in 2008. Here's a key issue. Racial and ethnic minorities, except Asians, continue to experience disproportionate burden of HIV diagnosis, as do men who have sex with men, MSM. In addition, disparities continue to widen among Black, African American, and American Indian Alaska Native males compared with white males, as well as among MSM compared to other males. Reducing the number of HIV infections will require full implementation of CDC HIV testing recommendations and expanded behavioral intervention for persons at risk for transmitting or acquiring HIV. Information regarding proven behavior interventions for populations at high risk has been published. Has been published? What? What is that? Has been published. Come on. HIV, AIDS, it's very important. When this report came out, and still in 2019, hello, I did a postdoc fellowship. Yes, Dr. B did a postdoc fellowship in HIV and AIDS from 1993 to 1995, 96 at Emory University. That's how I was able to do my postdoc and get my MPH at Emory. It's through a HIV AIDS postdoc fellowship from NIH. Thank you, by the way. And I actually did field work in Atlanta, Georgia, and investigated and went into the communities of Atlanta, Georgia. With my, by the way, I had my young family then there too. My wife and young daughter, my baby daughter, living in Atlanta. Loved it, by the way, but did field work and worked in the communities and worked with Hispanic, Latina women, Black African American women, and white Caucasian women. And the reason why I was looking at actually working with case workers who were working with HIV/AIDS patients in Atlanta, Georgia, back in the day. So this information is extreme. This data is very important because they still say disparities continue to widen among African American and American Indian Alaskan natives compared with white males, as well as other MSM compared to other males. But they didn't provide any publishable intervention. I don't like that. Sorry about that, CDC. I didn't like that. Okay, next. Diabetes. United States marked disparities in age. Standard prevalence of diagnosis of diabetes among U.S. adults were found in this study. Wow. No evidence indicate that racial and ethnic disparities in prevalence and incidence of diagnosed diabetes decreased from 2000. No evidence. However, socioeconomic disparities worsened during the same interval. Then they mentioned the task force on community prevention strategies, effective evidence-based interventions for diabetes prevention and control. I don't like that. Be specific. Provide the interventions. Provide the specific state or community interventions. Just don't say the interventions targeted at vulnerable groups identified in the study might increase the effectiveness. Come on, CDC. Dang. Another missed opportunity. And then finally, hypertension and hypertension control. U.S. 2005-2008 report examines disparity. And now this is part of my dissertation research back at Wayne State University in Detroit, Michigan, baby. Yes, so I know about hypertension, high blood pressure. I actually had a blood pressure gauge and measured people's blood pressure in the community in Detroit. Back in the day, from 1984. I actually started in 1983, but I started to do my fieldwork in 1984 to 1988. So I'm very familiar with hypertension. And matter of fact, my relatives have hypertension. I have hypertension. I'm on antihypertensive medication. Wow, did I say it? I'm going to get personal in these podcasts. You can't get more personal than that when Dr. B says, yes, I am hypertensive and I am taking antihypertensive medication right now in 2019. Yes, I am. And so this is so important. That's the reason I don't take this for granted. I'm just not reading the data. This is me. Hello. But in this report, it says I'm getting to it. Men, adults age 18 to 44, Mexican Americans, foreign-born adults, non-obese adults without health insurance, diabetes, or disabilities, prevalence of hypertension control than their counterpart. Basically, they said a population-based policy system change approach to prevent and control hypertension is considered more effective than interventions designed for individuals. I disagree. Home blood pressure monitoring as a part of routine management of hypertensive patients could include recommendations that patients be reimbursed for a monitor. I disagree. Okay. What got me, oh my God, what really got me to be proactive in controlling my hypertension, my really moderate hypertension was that it fit my lifestyle, and I had a physician who really worked with me. So that was more individual. It wasn't community based. It wasn't about and I monitored my blood pressure, but I did not fortunately need constant monitoring. It was the one-on-one relationship with my healthcare medical provider and getting him to explain the various factors that increase my blood pressure. That's the reason why and today is controlled. My blood pressure is controlled. I'm 60 years of age. My blood pressure constantly increased. Even though I'm a very active male, physically active, eat healthy, very active. But that's where your genetics, your biology comes into place as an African American male. And also I have a history of hypertension in my family. My dad, my mom. So hypertension control is very real to me. And yet this report was very distant. Yes, very distant in its reporting. Because it says older adults, non-Hispanic blacks, U.S. born adults, and adults with lower family income, lower education, public health insurance, diabetes, obesity, and disability had a higher prevalence of hypertension than their counterparts. Yeah. I got that. But the intervention did not provide much support. Okay, I'm 22 minutes in, roughly 22 minutes in. So there you go. Again, I'm further disappointed in this CDC report because they didn't provide specificity. They didn't provide good follow-through. It's good to report the data. I commend CDC for reporting the racial and ethnic disparities data. But when you do that, provide specificity on the intervention. That's basically what I'm criticizing CDC on. Yes, I said it. And I even did a postdoc fellowship. And I have friends who work at CDC. I love CDC, by the way. I do love it. Oh, by the way, I was fortunate to meet the former CDC director, David Satcher, when he was director of CDC. And I worked in the Office of Minority Health when I was on a postdoc fellowship there. So I feel very much connected with CDC. But in their reports, they just have to take it another step. Okay, so this particular Ethnic Health Disparities Report, show number 9, looked at health outcomes, morbidity, and we looked at obesity, preterm births, potentially preventable hospitalizations, current asthma prevalence, HIV infection, diabetes, and hypertension control. And we're putting a personal stamp on this one, baby. Yes, if you have any questions, I'm serious about this. If you have any questions, comments, please do not hesitate to email me at ejb678@gmail.com and subscribe to my podcast, the Ethnic Health Disparities Podcast Show. Thank you, folks. Peace out, folks. It's been fun again. Tell me about it. We out. We are officially out on the other podcast show. We out. We're done on the stopwatch. We're done. We are out.